So guys, let's move to another topic, which is steroid psychosis. When we are talking about steroid psychosis, we need to understand that we know that above kidney there is adrenal gland, which has medulla and cortex. From the cortex, it releases mineralocorticoids, glucocorticoids, and sex steroids. The glucocorticoid, the main one we talk about is cortisol. Okay, and the glucocorticoid, the cortisol, it has somatic manifestations which are well understood and well taken care of. But there are neuropsychiatric manifestations as well. But these neuropsychiatric manifestations are poorly understood. So, when these neuropsychiatric manifestations they go abnormal, like the if it causes disorder, so it will lead to steroid psychosis. Steroid psychosis. See, you have to understand that there is not a lot of literature that is available on steroid psychosis. Okay, a handful of articles are available. The thing is that they have taken affective symptoms, behavioral symptoms, and cognitive symptoms, lumped all together and put it together under the umbrella of steroid psychosis. So, steroid psychosis does not essentially means that psychosis like delusion or hallucination has to be there. Okay, so the manifestation of excessive glucocorticoids stimulation, this the whatever features will come, that will encompass under the term of steroid psychosis. So I am telling you this because it is not essential for psychosis to be present for it to be called as steroid psychosis. Okay, fine. So you know that the glucocorticoids, it mediates its effects through glucocorticoid receptors and through mineralocorticoid receptors as well. And glucocorticoids use is very common, especially in the autoimmune disorders, the cancers, they are used a lot. Fine. This was the basic. Now we start with the topic of steroid induced psychosis. We have seen the basic. What are the risk factors? See, steroid induced psychosis is your short note, 10 marker. We will try to cover it in 10 headings, 10 points, so that you get ready for your short note. Okay, so what are the risk factors? So one risk factor that has been found in literature is the steroid dose. So higher dose, higher chances of steroid induced psychosis. Fine, fine. The steroid dose, they have said that if the dose is less than 40 mg, we are talking in the prednisone equivalents. If the dose is less than 40 mg, the incidence of psychosis is nearly 1.3%. But if the dose is more than 80 mg, the incidence goes as high as up to 18.4%. And between 40 to 80 mg, it is nearly 4.6%. Okay, so steroid dose is one of the recognized risk factor. Steroid dose is one of the recognized risk factor. Just remember that dose does not predict the onset, the duration, and the severity of steroid induced psychosis. It means that higher dose does not mean that it will be a more severe psychosis. Okay, dose is correlated with the higher incidence. Higher incidence, it is not correlated with the onset, duration, and severity. Okay, one. Second risk factor is gender. Females are more prone for steroid induced psychosis. Third risk factor is if there is any underlying physical illness. In literature, we have seen that steroid induced psychosis is higher in SLE patients. In SLE patients. Okay, in SLE patients. Then hypoalbuminemia and concomitant medicines used. These also lead to high chances of steroid induced psychosis. Which medicines? Like ketoconazole, estrogen, clarithromycin. They all inhibit what? CYP 450. Okay. Which step? Hydroxylation and oxidation. So they will increase the level of this if taken with steroids. So these will increase the level of steroids, which lead to higher chances of steroid induced psychosis. Fine. So you have understood the risk factor. The risk factors are steroid, the dose of steroid. Okay, but the dose of steroid does not predict what? Onset, duration, and severity of steroid induced psychosis. It only predicts the incidence, like higher incidence will be there. Okay, then female gender is another risk factor. Then any underlying physical illness if there, hypoalbuminemia, any concomitant medicines which will inhibit CYP 450. Okay, this is all for the risk factor. Then what are not risk factors? See, if you get MCQ, okay, for risk factors of steroid induced psychosis, what options do you not falter with? Age is not a risk factor. Past psychiatric history is not a risk factor. Okay, okay. Then past psychiatric history, then whether it is an IV or oral steroid, basically route is not a risk factor. Okay, whether the dose was given in pulse or daily. Okay, so basically frequency, these are not the risk factors. Okay. Yeah. Let's say a person has been given steroid previously and he developed steroid induced psychosis. Can we re-challenge? Can we re-challenge? Yes. See, you have to understand that previous uneventful use, previous uneventful use of steroid. Okay, previous uneventful use of steroid. This is also not a eventful or eventful or uneventful use of steroid is also not a risk factor. Let's say the person had some psychiatric illness when he used previously. Can you give him again? Yes, re-challenge is allowed because because the past history does not predict the future episodes. Past history does not predict future episodes. Okay. There will be Viva questions also in between that we will be covering. Okay. So you understood what are the risk factors, what are not the risk factors. So we have seen one basic point, one risk factors. Coming to nosology. Nosology, we will only see DSM-5. In DSM-5, it comes under medication-induced psychosis. Medication-induced psychosis. Fine. Fine. Okay. Now coming to the main part, which is the neuropsychiatric aspects. Neuropsychiatric aspects. See, when we use steroids, corticosteroids, okay, it induces psychiatric syndromes. Okay, but these psychiatric syndromes are complex, unpredictable, and severe. So they also range from mild affective symptoms to full blown frank psychosis. But the relation of the factors are so complex that not much of studies has taken place. Okay, if we take average incidence, it has very high variability, 2 to 60%. 2 to 60%. Average is taken as 27%. But this has very high variability because the definition of a person with steroid induced psychosis, basically the criteria to include or not include in the studies, in various studies have differed. So that is why there is very high variability in the incidence. Okay. Then if they ask you about etiopathogenesis, see, you have to understand that etiopathogenesis is poorly understood. Just remember that the steroid induced psychosis is usually the extreme version of a patient's usual stress reaction. of a patient's usual stress reaction. Okay, etiopathogenesis is poorly understood, but it is said that because steroid is what? Steroid is stress hormone. So whatever the person exhibits normally under stress, the steroid, when excessive steroid will be there, that will be an enlarged or the extreme version of patient's usual stress reaction. Fine, understood. So when we come to the clinical features you have to understand that they are diverse, they are diverse affective, behavioral, and cognitive symptoms that we encounter. Okay, and all these are lumped together to form the term steroid induced psychosis. So without psychosis also steroid induced psychosis can be termed. Okay, so there are two MCQs. Affective, what is the most common affective symptom? Two different MCQs. Most common affective symptoms: euphoria, irritability, and anxiety. Okay, but most common affective disorder associated with steroid induced psychosis, these are depression and mania. If you have to choose, depression more than mania. In long term depression, in short term mania. Okay, okay, fine. Coming to the clinical features, see, first case report is nearly around 1950. The case report of steroid related altered mood, behavior, and cognition. It is around 1950. After 1950, there were a group of scientists which gave 10 patients ACTH, and they saw that these patients developed severe psychiatric symptoms, out of which some developed increased joviality and increased optimism. So severe psychiatric symptoms, joviality, optimism. Okay. Later, this is important, Rome and Boland, they also gave ACTH to their patient, and they labeled that there were four grades of ACTH response. What are the four grades of ACTH response? They said that grade 1, 2, 3, 4. Grade 1 and 2, they were milder. Like grade 1 was associated with general feeling of well-being plus increased feeling of stimulation, like there was increased concentration, increased energy, the patient felt clarity in his thoughts. So after giving ACTH, this was one group. Okay, second group second group felt more elevated mood. In the group 1, it was just a general feeling of well-being. The second group felt more elevated mood. Okay, they also felt restlessness, insomnia, increased psychomotor activity, and something like flight of ideas, but not exactly flight of ideas. And they said that to all the patients whom they gave increased ACTH, around 60% fell in group 1 or 2. Okay, group 1 plus 2, 60%. The group 3 suffered from severe anxiety, rumination, anxiety reaching to the level of obsession. There were immediate mood swings, indifference, crying spells, and flight of ideas. Flight of ideas. Okay. And the group 4. Group 4 developed hallucination, delusion, extreme mood variations. Nearly 40% of the patients to whom they gave this ACTH, they fell in category 3 or 4. So they, Rome and Boland, they said that there were four grades of ACTH response, and these are all the symptoms. The milder ones are general feeling of well-being, increased concentration, then energy will increase, the patient will have more stimulation, he will have clarity of his thoughts, patient will feel better, elevated mood, increased psychomotor activity, but then restlessness, insomnia will also be there. But in grade, if we the higher grades were grade 3 and 4. Severe anxiety, the patient even had obsessions, ruminations, then crying spells, flight of ideas was there because the thoughts were pacing. Then in the extreme stage it was hallucination, delusion, and extreme mood variation. Okay, so Rome and Bolland, they gave ACTS to their patients, and they gave the 4 grades of symptoms. Okay, so what were the what are the clinical syndromes associated with steroid induced psychosis that we need to study? See, mania, depression, delirium, psychosis, and suicidal ideations. Okay, these are the clinical syndromes that we need to study. What is the prevalence or what is the incidence? Mania 28 to 54%, depression 25 to 40%, delirium 13%, psychosis 11%. Mania is most commonly seen when short term therapy, depression in long term therapy. Okay, short term therapy and long term therapy, and this is your MCQ. Short term therapy mania, long term therapy depression. Okay, okay, fine. Coming to the cognitive symptoms. Cognitive symptoms can be mild, can be severe. The milder forms are the associated with the verbal or declarative memory impairment. And if they ask you what are the most common cognitive symptoms which are associated with steroid use, that is verbal or declarative memory deficits. Okay, then there is easy distractibility and decreased attention span. Okay, fine. Severe forms of cognitive symptoms include delirium, dementia. Okay, delirium, dementia. And what is the mechanism attributed? See, glucocorticoid receptors are present in hippocampus. Okay, and there is excess of glucocorticoid, so toxicity is there. So there is the hippocampal atrophy takes place. Hippocampal atrophy takes place. Fine. So these are the symptoms that we need to see. Okay. So when we see the symptoms, we know what will occur, but when it will occur, onset of symptoms. So you have to remember one line here: 83% symptoms. Remember 90, okay? You will not remember 83%, I know. So 83% symptoms occur within 6 weeks. Okay. So there is a timeline that we have got in literature: 39% symptoms, 1 week; 62% symptoms, 2 weeks; 83% symptoms, 6 weeks. 6 weeks. Okay. This means that 39% people who are using steroid will develop steroid induced psychosis within 1 week. Okay. Okay. So now we have seen everything, and now we come to the management. Management will include prevention and treatment. Okay. So if you have a patient of steroid induced psychosis, what is the best step? Best step is cessation of steroid. Let's say cessation is not possible. Then what is the best step? Dose reduction to minimal effective dose. Okay. Let's say patient with steroid induced psychosis, dose reduction also not possible. And steroid induced psychosis, let's say, is in agitation or he's having suicidality, then you will add mood stabilizers, or antipsychotic. Mood stabilizers, antipsychotic. If suicidality, add antidepressant. Okay. There is if they ask you FDA approved drug to prevent steroid induced psychosis, nil. There is no drug. Okay, no drug. Fine. So still you will use some drug. So drugs used to prevent steroid induced psychosis, but these are not FDA approved. Okay, one is lithium valproate, basically mood stabilizers, lamotrigine, and gabapentin. Fine. Fine. Then if they ask you that which antidepressants, about antidepressants, can you use TCA or not? See, most of the review suggests that TCA can be used, okay, good for treatment. But there are certain reports which have told that worsening can occur with TCA. And what is the mechanism of worsening? That TCA has high anticholinergic activity, which can lead to delirium. And this can worsen steroid induced psychosis. Okay. Okay. For antipsychotics, what will you prefer? SGA is preferred. SGA is preferred. Okay. Fine. Till when you expect the symptom resolution? Symptom resolution. See, for delirium, it takes few days only. But for psychotic symptoms, it can take few weeks. For mood symptoms also, it can take up to 6 weeks. Okay. After stopping the offending agent, and if you're not able to stop, then you have to add drug. Okay. But the best strategy, if they ask you best strategy for management of SIP, steroid induced psychosis, is stop the drug. Stopping steroids, we found that 92% patients improved. Okay. Second best is adding psychotropics. On adding psychotropics, 83% were improved. Okay, what is super best? If you combine both, stopping drug and adding this psychotropics, we found that 100% patients improved. Understood? Okay, so this was what? This was steroid induced psychosis. When you have read steroid induced psychosis, read just 2 lines about corticosteroid withdrawal syndrome. See, if you are unable to taper steroid, okay, slowly, if you're not able to taper steroid slowly, it can lead to what? First effect, or I would say bad effect, it can lead is HPA suppression, and which can be a cause of secondary adrenal insufficiency. Okay, first. Secondly, it can lead to resurgence of disease for which the steroid was going on. Okay. Thirdly, it can lead to corticosteroid withdrawal syndrome. So whenever you are not able to taper off steroid, so 3 things that come to mind are HPA axis suppression leading to secondary adrenal insufficiency, recurrence of the disease that can occur, and corticosteroid withdrawal syndrome. What are the symptoms of corticosteroid withdrawal syndromes? Depression, anxiety, fatigue. These are the common ones. Then delirium and mania are the less common ones. Okay. And in how much time the symptom resolve? This is 2 to 8 weeks. Okay. Fine. So I end my topic here. The thing is that this topic is short. The reason being that literature is not available. Okay. I could not find a lot of articles. If you find some, you can add. So in steroid induced psychosis, first we understood the basics. Then we read about the risk factors. Then we read about the nosology, clinical features, okay, certain viva questions we saw, okay. Then we saw the management, prevention and treatment, and then we read about corticosteroid withdrawal syndrome. So this much will help you gain marks in your exam, okay. I have given you enough to write a 10 marker question. This usually comes as a 10 marker. It is not that well given in the books, okay, but then they ask you this, so I expect you to read it here. And wherever in some article or in some book you might find a paragraph, you might find 2 lines which I have not given you, you can add it here, okay. But you will not find a lot of difference, because I had searched around 50 odd articles, then I could prepare these things. So I don't think that there is a lot that you can add over here, okay. Thank you.